Hi, I'm Dr. Alexey Danilov, professor in the Department of Hematology at City of Hope National Medical Center in Los Angeles, California. And here I'm joined by Dr. Ben Heyman, who will talk about the research he presented at ASH annual meeting in 2023. So Dr. Heyman, please introduce yourself.
Thank you so much for having me. My name is Ben Heyman. I'm an associate professor at UC San Diego, a hematologist. And it's a great pleasure to be here to talk to you a little about some of the research that we presented at the 2023 American Society of Hematology annual meeting.
Excellent. So let's talk about the abstract that you presented on Venetoclax data, which compares Venetoclax-based treatments in patients with relapsed refractory chronic lymphocytic leukemia. So can you please summarize what you have found?
Sure. Well, we wanted to, I'm sure as you know well, Lexi, venetoclax has been a great advance for patients with CLL. And so we wanted to look at kind of what is the optimal therapy for patients in the relapse setting. They're kind of different, ways to administer venetoclax. The FDA-approved way, based on the Murano study, is venetoclax plus rituximab. But also initially with single-agent venetoclax for patients with deletion 17p. But I think for many clinicians, we give venetoclax, maybe in combination with obinutuzumab, sometimes certainly in clinical trials, administer in combination with BTK inhibitors, sometimes also off trial as well. So we looked at kind of 100 patients who we've at our cohort as a single center at UC San Diego over the course of about 10 years, dating back to 2013 to 2023, and kind of looked at our experience of how they were treated with venetoclax in the relapse refractory setting. And so over those 100 patients, most of those patients kind of had kind of higher risk disease, defined as having kind of advanced RI stage, kind of high RI stage risk. If you look at their cytogenetic abnormalities, most of those patients, about a quarter of them had high risk cytogenetic abnormalities with deletion 17p. A third of them had complex cytogenetics. 3/4 of them had high-risk features such as an unmutated immunoglobulin heavy chain. And then also, a lot of them also had kind of high rate of genomic mutations. We know that also has really a big implications when we think about venetoclax-based therapies. So high rates of kind of genomic mutations as well. And so we wanted to kind of look at kind of seeing what was our experience in general. And so we defined our kind of outcomes first to look at was what was better, looking at venetoclax monotherapy versus combination therapy. Patients either received venetoclax monotherapy, which was about half the cohort. If you look back, this looks back to 2013. So a lot of patients were initially getting venetoclax monotherapy, and then the other half of the cohort got either venetoclax plus rituximab, venetoclax plus obinutuzumab, or venetoclax plus BTK inhibitor, which typically was just ibrutinib. And so when we looked at just comparing venetoclax mono versus ven combo, we saw that overall, from a progression-free survival standpoint, overall ven combo seemed to be significantly improved from a progression-free survival, which, not unexpected. We kind of see that in general for venetoclax-based therapies. And so then we wanted to look at specifically the different kind of combination therapies. And so when we looked at the combination therapies themselves, Ven-R, Ven-G, or Ven plus BTK inhibitor, we saw that while there was not a statistical difference between the three, there did actually seem to be a trend that actually venetoclax plus obinutuzumab or venetoclax plus a BTK inhibitor actually seemed to have improvement in progression-free survival over venetoclax plus rituximab. So again, lends credence to a lot of what we do in practice, as opposed to when I said what is kind of the approved regimen in the relapse setting, that we did see improvement in progression-free survival. Similarly, what we did find a little bit was surprising when we looked at kind of MRD data. All the regimens themselves seem to really have high rates of undetectable MRD when we looked at kind of using multiparametric peripheral blood flow cytometry to a level of 10 to the -4th. Kind of all kind of had similar rates of of UMRD around 65–70%. So there wasn't a major differential aspect on MRD by itself that could kind of explain the PFS benefit. And then when we looked at kind of the factors that really dictated who had what kind of would predict kind of who would have better response to venetoclax therapy. Not unsurprisingly, what we see typically with patients who get venetoclax, those patients that had 17p deletions or TP53 mutations, those patients had inferior progression-free survival, irrespective of the treatment, whether it was ven mono or combination therapy. And then one of the other major factor that seemed to portend a good prognosis was that for the patients that we did have MRD analysis on, those patients that actually maintained UMRD a year off of therapy, so those patients who had who took a fixed duration approach and then maintained MRD negativity a year off of therapy, those patients seem to have actually quite excellent long-term kind of durable remission. Mm-hmm. So it kind of was a nice kind of prognostic impact if we're kind of trying to counsel patients, how long do we think that this remission would last? Mm-hmm. So I think it was not groundbreaking research, but kind of solidifies a lot of what we kind of already are doing in practice, kind of taking some of the data from CLL 13 and CLL 14, what we kind of using in the frontline setting and potentially kind of corroborating to what we already see kind of in the relapse refractory setting and potentially, we do see with Murano that Ven-R is a 2-year regimen. And so, certainly if we're thinking about adapting kind of venetoclax or venetuzumab regimen in the relapse setting, certainly that does offer patients the potential to get a shorter duration of therapy. And certainly trials like things like the revenge, kind of looking at repeating CLL 14 and kind of regimen in the relapse setting will kind of hopefully solidify some of these findings and things like that.
Yeah, so it's interesting. So you saw improved progression-free survival with venetoclax combinations, even though venetoclax single agent is typically continuous, right? I assume
Correct.
patients
Yes.
who were treated with one venetoclax single agent were on continuous therapy versus combinations are actually time limited. So that's actually a very interesting, if not surprising, finding. What do you think of that? What do you think explains that? Because sometimes we talk about, for example, well, this patient is high risk, maybe they should continue venetoclax beyond time-limited therapy, even when a combination is used. I know some of our colleagues propose that for patients with deletion 17p. So does it mean that more venetoclax is not always better?
Yeah, I mean, I think we see that, right? I think we see that pretty definitively from the studies. I guess in the combination therapies, we see that pretty definitively that for patients, I guess if we look at MRD data, right, that if we give for those patients who maybe don't clear MRD after 6 months of kind of combinations, Ven-R or Ven-G, that more venetoclax doesn't seem to facilitate further clearance of CLL. And so certainly you're probably going to keep pressure on the leukemia cells, but that may and that might essentially give you unwarranted longer term effects, such as potentially leading to mutations, if you kind of do a continuous therapy. So yeah, I think it's certainly it's an interesting, it's certainly a good point in that, giving continuous therapy may not necessarily it can have more potential side effects. You have to do the risk of mutations. And there, later on can risk maybe rendering venetoclax ineffective. And so certainly you may not want to go back to a ven monotherapy in the future, but if you're thinking about a potential combination approach with the BTK inhibitor in the future, then you don't want to potentially lose that as a potential option in the future for them.
Right. So do you think there is still room for venetoclax monotherapy in CLL?
No. Oh, okay. Yeah. I mean, no, not as a real treatment. Again, this was kind of, this was, when venetoclax, of course, our data is, we can only use what we have. But I think in general, for most patients, we're not thinking about giving ven mono in general.
Yeah. Thank you very much. This is a very helpful discussion and certainly illuminating for our patients. Thank you. Thank you again for joining us.